My name is Atibadi Damilola, and I'm a clinical embryologist with Nordica Fertility Center and also in charge of the PGD process here in Nordica. Now with me here, I have Monique. Monique is especially visiting us professionally from all the way from Spain, Brazil. I can't begin to count the number of countries that you've visited. It's nice to have you here, Monique.
Thank you very much.
So today we'll be talking about PGD, PGS as it applies to helping couples to select genetically normal babies. So what I want us to do today is for us to explain or find a brief explanation, very simple overview of what the PGD, PGS process is about.
Okay, so thank you, Lola, for this interview. It's my pleasure to be here with you and your team in Nigeria. Well, PGS means Preimplantation genetic screening. This is a very important test, a genetic test performed on embryos during IVF treatments. This test will help us to find the normal embryos to be transferred to the uterus by the analysis of all 24 chromosomes, including X and Y, to screen abnormalities, chromosomal abnormalities, and find the good embryo to be transferred to the uterus.
Yeah, I like that you said it's used for all the 24 chromosomes, including the X and Y, which is why it's becoming much more popular in this environment, especially in the application of sex selection and also for sickle cell anemia as pertains to PGD, whereby we have a couple AS and they've gotten married and we need to prevent them having a child that has sickle cell disease. Now, having said that, I also like us to look a little bit about what the process of PGD is about. I know that with PGD, we need IVF with PGD, in conjunction with PGD. So sometimes the couples are not necessarily infertile, but we need to apply IVF as well. So can you just throw a bit more light on this?
Yes, the process of PGD starts with IVF treatments, and then we need to do the biopsy in these embryos. So the biopsy is the removal of one or few cells from the embryo, and finally these biopsied cells will be analyzed in a lab, chromosomally analyzed in a lab, and then all the good embryos or the normal embryos will be able to be transferred to the uterus. So this is an example of a day 5 biopsy. So here in this case we have the trophoblast cells and also the inner cell mass that are inside the embryo. So we need to aspirate the trophoblast cells that will form the placenta. So in this case we're not going to damage the cell that from inner cell mass that will become to the baby. Okay?
So in actual fact, what you're actually telling us is that this is a day 5 embryo, and then we have a part that is destined to become the baby itself and the part that is destined to become the placenta. Yes. So we are not in any way altering the baby itself if we do take a part of it to send to the genetic lab for any form of analysis.
Exactly. So we need to aspirate the trophoblast and to do the laser shots in the gap junctions of the trophoblast. So this cell will be put inside that tube and finally be sent to the lab, to the genetic lab, to be analyzed chromosomally.
While the embryo itself still stays within the laboratory, it doesn't move, it doesn't have to be transported. It's only a part of the embryo that is being transported from one place to the other. So it's not as if the embryo has to move from one location to the other. We just take a part of it and then send to another place for genetic analysis.
Exactly, to the DNA analysis.
Yes. Having said that, there's another group of people I would like us to talk about, and that's the older women group. Now, in this part of the country, we have a saying that says that a woman is like a flower and then withers with time. Basically, what that means is that scientifically, what it depicts is that as the woman ages, her fertility potential really declines. And so theory has told us that by the age of 37, there's a sharp decline, and there's also a higher risk of having abnormal children, syndromic children, such as Down syndrome and all the other syndromes that we do have. Now, how can PGS be used to help in a way to help these women achieve viable pregnancy and also a healthy child at the end of the day?
Well, the rhythm of life has caused more and more women to decide to become mothers later in life, when their fertility is reduced. A woman is born with a certain number of oocytes which will have the quality reduced by the age, and also the chromosomal abnormality will be increased by the age. So when an embryo is found as normal by the PGS testing, the chance to have a pregnancy, the chance of having a pregnancy is higher than 60% in women older than 40 years old. In women over 40 years old, there is a higher chance to have to find all the embryos as abnormal in PGS testing. But when we have normal embryos founded by the PGS testing, the chance of having pregnancy is about 50% for them.
So in essence, what you're actually saying is that in treating older women, especially in IVF, we can use PGS to help improve the efficiency, increase a little bit the success rate of IVF, as well as ensure having a normal child. In essence, that's what we're trying to say. All right, I'd like to take us back to the process of PGD-PGS, where we've established that we need to do IVF in conjunction with PGD in order for us to be able to genetically select embryos that are normal for transfer. But from experience, I've also noticed that sometimes for us to complete a PGD cycle, we'll need more than one stimulation of IVF. So can you just please throw a bit more light on this?
Yes, as we know, fertility and quality, the oocyte quality might be reduced with age, while chromosomal abnormalities may be increased with maternal age. So sometimes only a single stimulation is not enough to have normal embryos to be transferred to the uterus, and a new stimulation is necessary to have more embryos to be tested by PGS and increase the chance of having a normal embryo to be transferred to the uterus. But it's important to remember that even in cases that when we have more than one stimulation, it's possible to find all the embryos as abnormal after PGS testing. So in that cases, it's important to have a plan B. This plan B must be considered.
So in essence, what we're trying to explain is that for us to have a complete PGD cycle, sometimes we will need more than one IVF stimulation. And IVF stimulation is the process whereby we would recruit embryos that are needed for PGD. Now, the process of PGD is very sensitive enough that we would need good quality embryos. So there are lots of hurdles for us to cross. We need to get good enough eggs, we need to get good number of eggs, good enough eggs that will develop into embryos, and then we also need to get good enough embryos. And sometimes one IVF stimulation is not enough to achieve it. And so sometimes we have situations whereby a couple has to do IVF about twice or 3 times for us to have enough embryos to send for genetic analysis and hence complete the PGD cycle. And of course, like Monique said also, we also agree that even after completing a PGD cycle, there's also that probability of having no embryo to transfer. That's in essence what you're trying to say. It's because all the embryos can come out abnormal and we can only transfer normal embryos. Saying that, I want us to look at the process of PGD itself, because I want to look at the accuracy of the PGD process. Here's a place where we're telling people that this embryo is normal, and so we can go ahead and transfer. So how accurate is PGD? Can PGD ever be wrong? Can we have a situation whereby we've said this embryo is normal and then we end up having an abnormal child at the end of the day? So is it 100%? That's my question.
No, the accuracy of this test is higher than 98%. So the chance of misdiagnosis is less than 2%. There are some reasons for the fact of this test is not 100% accurate. So the result of PGS is based on the analysis of one or some cells of the embryo, which means that the PGS technique assumes that all the cells from an embryo are chromosomally identical. But however, we are still not able to say this is 100% true.
So in actual fact, in essence, the way I always like to explain it is that PGD cannot entirely replace prenatal diagnosis, the amniocentesis and the CVS. But what it will do is that while PGD is giving us a 98 to 99% assurance of diagnosis, what prenatal diagnosis is doing, for example, we'll take sickle cell, for example. Now, a couple has a 25% chance of having a sickle cell child if they are both AS. Now, what prenatal diagnosis would give them is that they have a 25% chance of having to abort that pregnancy. And so the stress of going through pregnancy, going through the process of prenatal diagnosis, which can be harmful to the pregnancy itself, and then having to abort that pregnancy if it is found to be abnormal. The ethical issues involved in it, the psychological and emotional issues involved with it. There's already attachment between the mother and the child, as opposed to PGD that we work on the embryos outside the body before implantation. That's basically what we are saying. But just like everything, it's not 100%, but it is very good enough that it is as good as 99 and 98%. Now, I also like us to differentiate between these percentages, because it's possible to mix it up and say that if I've done a PGD cycle, I have a 99% chance of having a successful cycle. The PGD cycle still has to be subjected to the success rate of IVF, because it's not all PGD cycles, even after we get normal embryos and then transfer normal embryos that will become a baby. So we have a 99% chance for the PGD cycle itself, and then about a 50% chance for the IVF cycle itself in terms of success rate in pregnancy. That's actually what we're saying. Exactly. Thank you very much, Monique. Is there any other thing you'd like to add to this?
Yes, I would like to say that the bitter truth is during IVF procedures, not all the oocytes can be fertilized in the laboratory, and not all formed embryos are good enough to be transferred to the uterus, and also not all transferred embryos can guarantee a pregnancy. Yeah. So which embryo will become a healthy baby is $1 million question.
Yeah, it really is $1 million question.
Yes, and hopefully in near future we will be able to pinpoint that good embryo which will become the much desired baby.
Yeah, I understand there's a lot of research going on to be able to help select the best embryos with as little harm to the embryo itself as possible, so that we can at the same time assure healthy baby and then at the same time increase implantation rate of IVF.
Yes, that's it. So until then, it's wise to remember that all babies comes from embryos, but not all embryos can become babies.
Absolutely. Thank you very much, Mary. And I'd also like to add that it's not enough just to have a child. I think the onus falls on us to ensure that people have healthy children. Thank you very much.
Thank you.